guidance, and the person who's doing the procedure knows what they're doing, it should not be a problem. I mean, the biggest concern from my perspective is that when you have a pleural effusion on the side of your remaining lung, that it's a harbinger that the disease has now recurred in the site where you only have one lung remaining, and it's a bad prognostic sign, unfortunately. So I think we can do procedures, but from a prognostic perspective, I think we have to be honest with ourselves about what it means to have that pleural effusion on that side. If it turns out to be positive, for example, for tumor cells.
And now, how do you manage, what is the rate of infections once you've inserted a pleuric catheter? I believe it's pretty low, am I correct?
It's 5% or less in general, and most of them can be managed by a course of oral antibiotics, leaving the catheter in place.
Okay, great. Radiation-induced pneumonitis, we hear about that a lot. Could you explain a little bit about what it is and then how is it managed?
Sure.
Yeah, so radiation pneumonitis is pretty much an inflammatory response that's caused by the ionizing radiation exposure of the lung. We really manage this with anti-inflammatory therapy. So for the most part, that involves a course of prednisone that is administered to these patients. The dose and length of the therapy varies a little bit between centers. So a lot of this is what centers have established in their experience of being helpful. But and in addition to that, you try to provide supportive care to the patient. Obviously, we are trying to limit radiation pneumonitis also, again, when we plan therapies for these patients. And that highlights again, the point that Dan already made, that this is really a team approach. And that's how we look at these patients, that this is a multidisciplinary team that's looking after the patient, where really